sponsored by the network, the European Reference Network GUARD-Heart, and this is the thematic area 4. And today we have a very interesting topic, which is cardiac rehabilitation in congenital heart disease. We have two speakers who are very involved in this topic in cardiac rehabilitation. The first one is Dr. João Rato, and then we'll have Dr. Curtis Wadey. And may I ask you, João, to start your presentation. João Rato is a pediatric cardiologist from Lisbon. He works in Santa Cruz and Western Lisbon Hospital Center. His main activities are related to exercise, and he is the founder of our cardiac rehabilitation program, which he named the HERO program. João, we would love to have you say your thoughts about this program and your experience in cardiac rehabilitation programs in congenital heart disease. Please.
Okay. Thank you very much for the kind presentation, and thank you for having me to talk about our experience. So, as Dr. Rui said, I've been involved in our cardiac rehab program, and I'm one of the founders of the HERO program here in Lisbon. This all began during my residency, when I've had the privilege of working with Dr. Rui in evaluating all our Fontan patients. And as some other people all across the world have found, patients who exercise actually do better. So sports practice predicts better functional capacity in children and adults with Fontan. And this, of course, makes a lot of sense in the Fontan circulation. Exercise and the muscle pump and the muscle contraction can help lower central venous pressure. Pulsatility, blood flow can help improve the pulmonary arteries, and the work of the myocardium can help in the long run to maybe lower diastolic pressure and lower LA pressure. And so the circuit may, in the long run, work better. But of course, not everything is just about physiology and improving our patients' anatomy. It's also mainly about their quality of life. This great study, landmark study just this year from the Bordeaux group, showed us that in the long run, cardiac rehab improves the health-related quality of life in our patients. And that's all that we really want. We want to help our very sick patients to gain a better quality of life and to achieve their proper place in the society and to be able and adults that can have an active life, okay? So that was the start. This is the start of everything. But of course, we have some real world problems in this field. Patients often do not exercise. And this is because the history of chronic illness, self-imposed precautions or fear to exercise, lack of regular exercise, decreased muscle mass, decreased exercise capacity, and the sedentary lifestyles that these patients have. All of these come together in it being very difficult to get them to exercise. And also, there are, of course, local differences. And Portugal, unfortunately, ranks very low in physical activity. In Europe, we are a very sedentary country. So we had to turn this around. We've begun into 2018. We have a heart center with adult cardiac rehab. We wanted to use this to our patients, our young patients, but we had a big obstacle, that it was the lack of a school work-oriented schedule. That is, we don't want to take people off their normal activities, be it school or work for young adults, and we wanted to improve on that in another schedule. We had some patients in this around this time, but it was not meant to be. And from 2018 and 2022, we had a lack of support for improving these kind of programs. Finally, in 2022, we established a partnership with the University of Human Kinetics in Lisbon, which is the university for exercise sciences, and we were finally able to start. So we established our program with the clinical team and clinical support. We were able to harness the university knowledge about these matters. This was a team that already worked in cardiac rehab with adult patients. We established a friendly schedule for people that worked, kids who go to school. We have some great spaces. We were able to get some funding from Oeiras City Council and even support from our parent association group, which is called Associação Coragem. And all of this came together to found our program. And since 2022, we started with adolescents and young adults. We assembled a clinical team, multidisciplinary, with a dietist, psychotherapist, some nurses joined us, and so on. And we had the beginning of our tele-rehab and pediatric modules in 2024. We've enrolled 42 patients so far, between 8 and 34 years. Of these, 27 remain active as of now. And one important aspect of our program, it is that it's an open-ended program, which is patients can stay in this program as long as they want. Because the program is not in the hospital per se, we don't have that kind of pressure to discharge patients from this program. I've drawn some guidance from the established literature, especially the papers from the Boston group, which have a long history with this kind of programs. This paper really details everything that there is to know about starting a pediatric cardiac fitness program, and it establishes the core competencies which guided me in the beginning: patient assessment, which is my part, of course, exercise training and physical activity counseling, which I do with the help of the university team, nutritional counseling, weight management, and psychosocial management. All of these are part of our cardiac fitness program. And also the guidelines from the Spanish group just this year in the pediatric patients with CHD have strengthened our protocols, especially regarding risk stratification, which is a big part of what a pediatric cardiologist can do in this program. So for risk stratification, we use a thorough evaluation at rest and during exercise. We do CPET in all patients with threshold assessment, and we use the forced risk stratification tool from the Boston group, which puts patients at 3 categories with light, moderate, or heavy exercise intensities that they call the force 1, 2, and 3 categories. They have some variables that they use to establish this risk assessment. They assess function, heart function, oxygen levels at rest and during exercise, rhythm. They have a subjective assessment of complex physiology, coronary risk, aortic dilation, and of course, elevated load, be it hypertrophy, volume load, pulmonary hypertension, or pressure load. And all of these variables come together in order to put patients in one training zone. And we have learned many lessons along the way, which I will exemplify with some clinical cases that I will present afterwards. We've learned that we can create super fontaines. Our program has a lot of fontaines, and we've managed something that we didn't believe to be possible at first, to create super fontaines, and then I'll explain what that is. We don't have to be limited by disease severity, and I will try to convince you of that. But we also have to acknowledge that we can only go so far, and that sometimes the rehab program is not the best option for our patient. Also, we have very complex patients, and we have to be creative in order to foster adherence to this kind of programs. And it is really much more than just physical therapy for them. So I'll begin with a role model. This is a young lady of 30 years old. She has tricuspid atresia, a Fontan circulation. Her ventricular function at rest is normal. CMR ejection fraction of the left ventricle was 54%. And during exercise, as you can see here, during exercise echo, she has a normal progression of her heart function. The oxygen at peak exercise by CPET is 87%. There are no arrhythmias, but her aorta is slightly dilated, 39 millimeters. Her hemoglobin was also low, 11.1, and ferritin was also low when she came to us. And I had to do the risk assessment, of course. The function was normal. The oxygen level, a bit low at 87%, which put her in a class B, but of course, this leaves some room for improvement. I think we can all acknowledge that 87% is not that really low. She had no arrhythmia. We've put there on the class B for complex physiology because she is a Fontan after all, and her aorta measured 39 millimeters, which also leaves a little bit of room for improvement. So I put her in a force 2 category, in a moderate training level, but of course, if she did well, we can also improve her towards higher intensity zones. And she did. She began with a VO2 that was 68% of the predicted, but with exercise, nutrition, and also very important, IV iron because of her anemia. 1 year later, she had improved to VO2 that was 85% of the predicted for her. And that really explains that we have created a super Fontan. So when the literature now publishes the papers about the super Fontans, and if it is even possible, we can say with confidence that it is, and we are very happy about it. But we also have some very severe cases. This is also a young man, 18 years. He has restrictive cardiomyopathy. He had a ventricular function already depressed at rest, 45%. And with exercise, the left ventricle remained more or less the same, but the right ventricle became more dilated, more dysfunctional. The PA pressure was above 2/3 of the systemic blood pressure. And he also had a history of some arrhythmias in the past, a non-sustained VT, he was medicated, and a subcutaneous ICD was implanted. But, of course, this patient was refused to the heart transplant list. But we have striven to give him everything that we could, and so he entered our cardiac rehab program. Of course, this is a severe patient, so his rhythm puts him in a class C of severity, and also his pulmonary hypertension is very severe. So this is a lower training category, and it doesn't leave too much room for improvement, but also, of course, is a very limited patient. But even then, he was able to improve his VO2 from 29% in 2021 to 56% 1 year later, and then towards 60% in 2023. And you can see him in this video playing football with his colleagues. Is the young man in the gray shirt in the videos. So even with this kind of disease severity, we were able to achieve, and he's very happy about being on a program he feels very good. And one important aspect, he was admitted for heart failure in 2020, which triggered all of these assessments. But he has never had another admission since then. And of course, we also have other severe patients like these ones, this 15-year-old with a Fontan circulation and exudative enteropathy, this 14-year-old also with a Fontan small bowel resection, and also another Fontan with 32-year-old and hemiparesis. And all of these have a lot to gain from this program. So that's why we believe that even the sickest patients are the ones probably that have more to gain from our program. But we can only go so far, and this last patient is a good example of that. She has tricuspid atresia. She did her Fontan at 5 years old. She has hemiparesis following a neonatal stroke. She entered our cardiac rehab program. She, on her echo, has good function, mild AV regurg, and no arrhythmias. But even after our program and a very good adherence and a very good effort, she hasn't improved in her CPAT. Her VO2 remained the same. The slope even was more severe, and the oxygen saturation was always low. And we realized why that was. She has a severe limitation to her preload, which is a severe reduction in diameter of the Fontan conduit, which decreases from 21 millimeters to 12 millimeters just before reaching the pulmonary arteries. And also she has the left superior vena cava still draining to the coronary sinus, which gives her a lot of desaturation during exercise. So, of course, she remains on our program, but we also know that she has to treat the obstruction and perhaps close the left superior vena cava in order to improve her parameters, especially the VO2 and parameters from the CPAT. Also, other times, we have to look at the big picture and we have to understand that cardiac rehab may not be the best option for our patients. This is a 16-year-old. He has hypoplastic left heart. He made the Fontan at 3-year-old. And he had a recoartation with severe ventricular dysfunction that was treated with a stent and GDMT, which is the medical therapy for heart failure. And he entered the cardiac rehab program. On his echo, already at rest, you can see that he has severe dysfunction that worsens a lot with exercise. As you can see, this is his strain at rest and this at peak exercise. Fortunately, there were no arrhythmias at rest or during exercise. After entering our program, he improved a bit. When you look at the absolute values of VO2, he has improved. The predicted percentage has remained the same, but because he has gained more muscular mass and more weight. And there are no other severe parameters. And he was put on the heart transplant, which made it even more important to be on the cardiac rehab program. But it really conflicts with the hours that he can go out with his peers. And he was feeling very sad in the program. He was not enjoying it. And so we reached a consensus that provided that he maintained an active life without risky behaviors, we'll waive formal rehab in order for him to proceed to his heart transplant. And he was happy about it, and he has remained active in his life and following our instructions, which is very good. We also had to get creative eventually to help to reach patients that are outside of Lisbon, especially in the Highlands, Madeira and the Azores, and also in Algarve. We have a lot of patients there, so we established our tele-rehab program 2 times a week to help these patients. And now we have our kids program. And this is a challenging class because they have severe diseases, as you can see here. And we have to be very creative in order to harness their energy and maintain them entertained and for them to adhere to our program. We have 3 fontaines, 1 Marfan with valvular prosthesis and pulmonary disease, 1 tetralogy of Fallot, 1 pulmonary atresia, and 1 dilated cardiomyopathy. And this program is much more about functional training and group sessions. So they not only are doing exercise, but also they are improving their motor skills and their flexibility and the skills that will be very important in their adult life and in their health. And it's really much more than just exercise. For some patients, this is an international patient that we have, and he wrote this message in English. That's why I put it here. And he tells us that he likes the teachers here, and he thinks that he found a lot of friends who are similar to him and relate to him. So he's excited to continue our program. So what does that tell us? We believe that young patients with heart diseases must lead an active life. And we believe that providing a safe way to exercise is essential to optimize our patient treatment. But our patients are challenging, and fostering innovation is important to ensure their adherence and that they stay on this program. And we have to always remember that the goal is for our patients to may, by his own efforts, to preserve or resume his proper place in society and lead an active life. And that's what cardiac rehab is there for. Thank you.
Well, João, thank you very much for your presentation. It's actually very interesting the way how you're dealing with these. I think we'll have some questions for you after the second presentation. So I'll just move on and introduce Curtis Wadey. Curtis is a research lead at Southern Health NHS Foundation Trust at Exeter. He works with the Children's Health and Exercise Research Center at this university, and his research interests include fitness, physical activity, and cardiac function in patients with congenital heart disease. Curtis, please.
Thank you. Thank you for the introduction. And can I just say that was a fantastic talk prior. I really, really enjoyed it, and it's great to see the great work you're doing. I'll just share my screen and get onto the talk. Please, can you see me? Just give me a wave if you can see.
Yes.
Yeah, excellent. Okay, I will see. Okay, so thanks very much for the introduction. So today I'm going to talk about cardiorespiratory fitness and rehab in young people with congenital heart disease. And so I'm going to talk very briefly, 20 minutes to cover this massive topic, but to talk about the importance of fitness, how we best index and measure fitness in this population, what the evidence base is around improving fitness, barriers to activity, and ways forward. And this is kind of crunching 4 or 5 years of research into 20 minutes. So if I speak a little fast, please excuse me. So I think what we need to understand, and I think you'll do, is just how important exercise and cardiorespiratory fitness is in this population. We looked at we did this systematic review where if looking for papers that took any CPET variable and they tried to associate that with morbidity and mortality in congenital heart disease. We found 6,000 titles, and we whittled them down to about 35 we included in a meta-analysis, and we produced this kind of monster meta-analysis. And on the left here, we can see all the different conditions, so Fontan, transposition, tetralogy of Fallows, and all the different CPET parameters that are commonly that were reported, more than twice on the right here. And key theme is that peak oxygen consumption was statistically significant predictor of major adverse cardiovascular events, regardless of the type of condition. So we know fitness is important, but there's lots of different ways of presenting fitness data. So we can look at absolute values, liters a minute, milliliters a minute, which is simple to interpret, but it's biased by body size. People with more musculature, who are taller, males, they have larger absolute values. So we need to index that somehow, or let me just see if I can move this out of the way. There we go. So normally what we do is divide it by the body mass, and that controls for body size, but it doesn't really, and it ignores body composition. So what it does is it makes heavier people appear less fit, and lighter people, it artificially inflates them to make them look less fit. And I always think around on heart transplant evaluations, all you need to do is make yourself a couple of kilos heavier, and that will drag your relative value down. We also have, if my presentation works, normative values, so percent of predictive. This is really intuitive and is great. You know, we expect you to be here, you're 100% of peak predicted, you're 80%, you're fine, you're 40%, maybe something's going on. The issue here is the choice of equation or reference values. There are over 60 different reference values in the literature. So which one do you choose? Which one is valid, etc. So we looked at these issues in congenital heart disease, and this paper with the Australian group, Rachel Cordina, we looked at how fitness should be best expressed in people with Fontan. And a bit of a boring graph, but on the y-axis here on A2, this is peak VO2 divided by body mass. On the x-axis, I haven't labeled that, but that's body mass. And you can see significant negative correlations. So what this is saying is it's negatively biasing heavier people, not necessarily because they're less fit, but just because they're heavier. It's a statistical phenomenon that was described in 1920, but we still carry on. However, if we divide by fat-free mass or measures of body composition, we create this beautifully size-free and size-independent metric. So we can fairly compare between an 8-year-old child and a 40-year-old man. We then looked at percentage predicted peak oxygen consumption. We wanted to know what equations people were using and how they were applying them to the population, and then taking one population, taking one equation and just seeing what happened when you applied it to a congenital heart disease population. In this paper, is what we found was there's huge variation in what equations people are using to generate their percent of predicted. We found that they were also poorly applied. So equations based on adults were being used in pediatrics. Equations based in cyclogometry were being used in running. And this all affects the kind of percent predicted value you're telling your patient they've achieved. We then took the Wasserman equation, which is the most used and most recommended, and applied it to a Fontan cohort. And what we found was that it just was not associated in any way to measured values. In the review processes of these papers, there were always grumblings around, yes, but these variables still predict fitness, so what's the point? And this paper's been under review for a few months now, but hopefully it will get published soon, looking at all the different ways we can index fitness. So absolute, relative to body size, relative to lean mass, and percent predicted. And this paper finds that by scaling to measures of lean mass, fat-free mass, maybe using a bioimpedance machine, it's more associated to patient outcome. So it'll improve our predictive abilities and diagnostic abilities going forward. So I've talked a lot about what the importance and how to do it. So how do we improve it? This is a Cochrane review we did some years ago now. So we've missed the Medro study, which is awesome, but this is due for an update. So if you're interested in updating it with me, please get in touch. We looked at primary outcomes, maximal fitness, health-related quality of life, and device-worn measures of activity. We had some secondary outcomes, and we were able to include 15 randomized controlled trials. Of these 15 trials, we had about 1,000 participants, and 500 of which were pediatric. So really low numbers if you think, congenital heart disease is 1% of the population approximately, and we've only got 500 pediatric patients. We had 3 types of intervention. Physical activity promotion. So this would be like a counseling session. Physical activity is good for you. Here's some guidance, go away and do physical activity. Exercise training, which is a bit more akin to the previous presentation, where people come into the center and they do some exercise under supervision, or they do it at home and they're monitored, their prescribed exercise, and also inspiratory muscle training. All studies measured the outcomes, say fitness pre and post the intervention, and only one study measured the long-term outcome at 36 months. We also risk of biased it. I'm not going to go too much into this, but this was the first Cochrane review that used risk of bias too. And the difference between this is that instead of risk of biasing a study as a whole, you break it down to the individual outcomes. If you want to look at the different studies and how they did it, that's described. If I just go to the meta-analysis we performed, we can see our 3 subgroups, so exercise training here, physical activity here, and inspiratory muscle training here. We found exercise training interventions did significantly increase peak VO2 in mils per kilo per minute, roughly 3 mils per kilo per minute, and no kind of differences in the other 2 subgroups. Overall, a non-significant 1.9 mils per kilo increase. So often people say, but what about different types of congenital heart disease? Are the more severe more likely to gain? Are the better off less likely to gain? We did a subgroup analysis, single ventricles versus tetralogy versus other just mixed congenital populations, and they all increased around 2 mils per kilo per minute. So everyone's got something to gain, is what I take out of that. Everyone loves a happy story. We also performed a meta-regression analysis. The only 2 things that were significant in describing why the interventions were effective were follow-up period and intervention length. So the longer the intervention, the less likely it was to make a difference, which is interesting. But when you plot these, what you can see is it's one trial really driving these associations. So when you've taken all the risk of bias and the grade analysis you have to do when you do it Cochrane, what we found was that cardiorespiratory fitness increases slightly, but there's a lack of long-term follow-up data, and there's a moderate certainty of evidence. Health-related quality of life, I haven't gone into, but only one trial found an improvement in health-related quality of life. Now, I'm not saying that physical activity interventions aren't good for health-related quality of life, but I think we might just be measuring the wrong thing. Maybe if we're measuring confidence and efficacy, that we'd be seeing huge improvements here. As this review found, only one study out of the 8 found a positive effect. Physical activity, we found that on average, people improved their physical activity by 10 minutes per day, which is good. And there were very low chances of adverse events. Out of the 1,000 people, there was only 11 adverse events, no serious adverse events, and no evidence of adverse cardiac adaptations over time. So small benefits, potentially, maybe big benefits, but low risk. Moving on to some kind of mixed methods research, which is a bit different. What we looked at was a UK-wide survey where we asked parents who had children with congenital heart disease what they thought about exercise, and do they do it? Do their children do it? And what was their clinical experience of that? We had 83 valid responses. 95% were mothers. The children were split 50-50 between boys and girls, up to 21 years old, and most had undergone cardiac surgery. What we found were that active adults made active children. If the parents were active, the children were active. If they had positive views around physical activity, their children did physical activity, which is great. What is less great is the clinical experience they received in the UK. 71% had never received physical activity advice in clinic. Of those who did, half said it was inconsistent between people or appointments. So this is one doctor saying one thing, another saying another. One quote is something along the lines of, one person being very unsure to another doctor saying, your child could be in the Olympics. 85% had never received an exercise test. The qualitative part of this coined the term knowledge is power and comfort. And what we found, it was because there was no or very little activity advice, there was very inconsistent advice. This filtered down to the school and the local environment. The school didn't want to take unnecessary risks, so they took them out of PE, of opportunities to be active. There was a lack of provision generally. Parents then feared that physical activity may do something bad to their child, and other injury prevalence, for instance, damaging pacemakers. And then this all filters down to the child. It's a psychosocial impact, not going out to play football with their friends. Just thinking back to that previous football clip in the previous talk, I think we should get him in the England squad after their recent performances. So practical ways forward. The Europeans have come out with some really good guidelines. It's a huge title. It's not as cool as the FORCE guidelines from the Americans in the previous presentation, but it's very useful. So this is ESDAPC and EAPC, all the acronyms. And what they do is they break sports into skill, power, mixed, and endurance. And they describe the kind of heart rate, blood pressure, cardiac output, etc. that these types of skills, these types of sports produce, kind of the physiological demand of these sports. They suggest a five-step process where you do a history and a physical exam, assessment of 5 baseline parameters, an assessment during exercise, you recommend the type of exercise, and then you follow up. Again, these parameters are very similar to the ones in FORCE. So looking at the ventricles, the pulmonary artery pressures, arrhythmia and oxygen saturations. And then you would look at these 5 parameters, and then you'd filter down to skill, power, or mixed sports. And then you could go back to the previous diagram and say, yes, you can play cricket. Another way is used. Another thing that would be useful, a useful resource, is from Heart Research UK, and they've got a Heart Hub. It's a UK-based charity. They have resources for children, teenagers, and adults, booklets with lots of information that talk about congenital heart disease. And at the back of the toolkit, there's a physical activity recommendations form. And it allows the doctor or the nurse to go through with the child and say the type of exercise that is recommended. So moderate exercise is allowed, durations, activities to avoid, so high risk of impact, activities of high risk of injuries. And then it kind of, you can tick down and then sign it off. And then this just gives that kind of the parents a little bit of confidence, something to give to the school to say, you know, this is appropriate for my child. So, summary of this talk: fitness is certainly important. It's you need to consider how fitness is measured and interpreted to go down the clinical decision making, bringing in all the other information you have at hand, blood tests, cardiac imaging, etc. You know, if the peak VO2 goes down, look at the child's weight. Has that increased massively? Fitness can be improved with potentially clinically significant reductions in risk. For the paper that's unpublished at the moment, is under peer review, a 1 milliliter per kilo increase in someone's fitness reduced their hazard ratio by 10%. And that was linear. So, and that didn't matter at what stage they were at, whether they were the least fit or the most fit, they all had something to gain. And the EAPC provide guidelines, and charity provide practical resources. Thank you. This is my amazing team. My PhD was sponsored by Canon, and Graham Stewart here, Craig Williams, Lindsay, Dan, Narul, and some physiologists from the Bristol Hospital. Thank you all, and I'm happy to take any questions. Thanks for listening.
Well, thank you very much, Curtis. That was an outstanding presentation, and congratulations for all the work you've done in this area. It's fantastic, fantastic. And it brings a lot of scientific information for all of us clinicians on where we should join efforts and what we should be doing in clinical practice. I would like to ask a couple of questions to both of you, and probably as people start asking questions through the chat or even live, I would like to ask João Rato, what about safety? Safety in your HERO program. Are you concerned with safety? Curtis showed us that the number of adverse events is very low indeed in these programs or in these sessions with increased physical activity. But what about a specific cardiac rehabilitation program where probably exercise is a bit further advised or stimulated than in a regular physical activity program? What about safety, João?
Thank you for that question, Dr. Rui. So we take safety very seriously. As Curtis said, there are the evidence shows that adverse events are rare, which is good. But in this kind of programs, confidence is paramount, and the people that are with us, they have to be confident that they can. A serious event can have catastrophic consequence for everybody involved. So we are very, we have to be very serious about this. And what we do, that thorough evaluation that we do with CPAPs and exercise echo, CMRs, and so on, it may look a little much, but it really gives us the confidence and all the data that we need for us to be sure of what that patient can do, especially the exercise echo. And I know Curtis has also some published data about this. Especially the exercise echo, it's something that really nowadays tells us a lot about. We don't do it in every patient that are a very there are some patients that we don't need to do it, as they are very well adapted, but in other ones where those gray areas, we feel very secure about it. And our CPAPs, we really push them to maximal effort. We are very strict in our maximal points in order for us to have the maximal confidence that they can exercise, because we don't push them to their limits on the cardiac rehab program. We are far from it, but we have to make sure that the thresholds that we are pushing them even those are safe. And of course, we also take some practical measures in the field. All of our staff is trained in the CPR. We have the defibrillators and so on. There we have the polar belts to measure heart rate. We have portable EKG devices in the university when there's any doubt about heart rate and about arrhythmia. So we have all those measures for us to feel confident that they are doing what we want them to do.
Great. Curtis, what about this question of safety, and how should we select the patients and try to create some type of risk assessment? How do you select the patients that need a stress echo, or the patients that shouldn't be involved in a specific program? What about patient? Is CPAT stress echo?
I think it's a good question. So I probably should have introduced. My background is a pediatric physiologist. I'm not a medic by trade.
Okay.
So all medic questions, I'm going to defer to Dr. Rateau. I think personally, you guys are at the cutting edge of what you're doing, and you're learning as you're going. I think what you're doing, the program you've presented is amazing, and I think I'd love every centre in the world to do this. I especially love that it's open-ended. It's not 12 sessions and you're done. You're trying to build lifelong habits, and I think that's really important. In terms of CPET, I think there's some good guidelines around different congenital heart defects and how regularly they should be having CPETs in terms of monitoring. In the UK, I can almost guarantee you, I don't have the data, but I can almost guarantee you these guidelines are not being followed in most centres, which is a shame because I think it's a really powerful tool. Exercise echo is amazing again, but very specialist. We do some work, but I would say I'd leave that to a cardiologist. So yeah, no, I haven't answered your question, but a good politician's answer, I'm afraid.
Okay, well, that's fair enough. That's fair enough. You're doing a fantastic job, and I am fascinated with all the publications that you have produced in the last few years, and I congratulate you and Craig and the rest of the group for the amount of work that you have been doing. We have a question from Mata, from Dr. Mata, and he asks if, other than the improvement, the clinical and echocardiographic improvement in the rehab patients, what about improvements in mental health and social inclusion? Can we actually measure that, or can we actually try to perceive how much this has been improved with the program? João.
Yes, thank you. We've tried to measure everything that we can. With our physical team measures flexibility, strength, and almost all of our patients have improved in those parameters. Our psychotherapists also measure all these kinds of social inclusion, mental health, and so on. I don't have that data with me. But what I also do the health-related quality of life questionnaires myself and the physical team in the university, so we can all have a more readily available data for us to compare these outcomes. Lots of them have had improvement. We use the PETSQL. I would like for you to comment on that, Curtis. I don't know if what do you think? If you have some experience with this kind of questionnaires?
Yeah, little bit. So we recently did a randomized control trial at Bristol Children's Hospital, getting children into a 6-month physical activity program. There were a lot of questionnaires, and the main feedback was, we hate questionnaires, don't make us do them. And actually, I think the most valuable information we got was just with a sit-down chat, and doing some kind of semi-structured interview. And I think I'm not a qualitative researcher, so I'm going to butcher this, and I apologize to anyone who is a qualitative researcher, but often I think it's overlooked. I'm a data guy. I love to see, improvements, tracking numbers, PQLL scores going up, but actually doing those kind of interviews where you can really dive in and get that kind of richness of the data, I think is actually missed, and I think we should be doing more of it going forward. But yeah, PQLL, I think if I was to choose one questionnaire, it'd probably be that one.
Yeah, what Curtis is saying, it's really true, because when the children hate questionnaires, they don't like to do it. And when you actually do those kinds of questionnaires, for me and for my experience, lots of them, things are great with them. Nothing's happening. They have adapted a lot. They are happy. Nothing's happening. When you apply those questionnaires to the parents, then that's another story. Parents have a lot to say about it. But then you're not measuring the quality of life of the kids. You're measuring the quality of life of the parents. So that's really different. And it's what Curtis is saying is true. When you sit down with these kids and you ask them what has changed for them, you grasp so much more than just with these kinds of questionnaires.
Well, I loved it once. I was watching a CPET with a child, congenital heart disease, on the bike. We were kind of shouting at the child, "Come on, keep going, you can do it." And the comments were, "Wow, I never knew my child could do that. Never really seen them sweat before." That is, that's the kind of confidence you can kind of instill just with a 15-minute CPET. So these things are, I think we can look into this more, and there's definitely some work to be done. But I think what your program is awesome. I'd love to come and see it one day.
Oh, please come and join us.
Okay,
We'll
Curtis, the last question for you. And although you're not a physician, but you're very much involved in all these programs and assessments, and you're looking at kids with congenital heart disease. And in your opinion, what's the best way for a clinician? We have lots of clinicians here joining the webinar today. What's the best way for a clinician to approach exercise recommendation? Because we all have very busy clinics, and we have patients with good heart function, poor heart function. Most of them have good heart function, fortunately, but all have different types of problems and diseases. What's the best way? Is that to provide them with the leaflet, the British Heart Research Group leaflet? Is it useful, or should we find a more easy way of recommending exercise generically for all patients?
Yeah, I think I think this is the big question. This is the hot topic. I don't know, but I think there are quite a few different options. I was speaking to colleagues at Southampton Hospital who are now putting in a process where it's like an MDT, and so they'll go and see the cardiologist for cardiology advice and medications and monitoring and things, but then they'll also see someone who's an exercise specialist or a nurse that has had training in these things. That's an interesting model. I think if you don't have the luxury of that, just raising the topic of physical activity, potentially the benefits, I think people come to the doctor and they're like, wow, this is the doctor. And if they say this is good, then I should go out for those walks. And you're saying it in front of the parent. And I think it will have some gravity to it. I think the written instruction helps where for that inconsistency we're seeing in the UK. So one person will say one thing, one will say the other. But then the parent could produce this piece of paper and say, well, this doctor said this. Can you explain why, potentially? Or, and I know you're probably going to get follow-up questions that you then don't want to, it's just going to make your clinic longer. But I think just generally raising it as a positive thing. I don't know what you would suggest, Joe.
Well, I usually tell all my patients, you need to exercise.
Yeah.
And I take 1 or 2 minutes at the end of the appointment to tell them, you need to exercise. And I look at them and I say, you need to exercise. And then it depends a lot on their reaction, actually. But sometimes it's a long talk, sometimes it's a very short talk, but I tell them, all of them. And I've been doing this for years and years and years. I don't know if it works. For some, it works. For some others, it doesn't. But I tell them all to exercise.
Yeah, that's amazing. That's amazing. We're in that RCT that we just did, the biggest win we had, where they were filling out physical activity diaries. The first time someone turned up, it was Xbox, PlayStation. The second time they came in, they had some walks on there. Okay. And I think just anything, just get them going in the right direction. But yeah, thank you. It's a great question.
Okay, I have one question from the audience, from Aneska Gom. Aneska.
Yes. First, I would like to say it was 2 very fantastic talks, and it was very nice to listening to that. And congratulations to such comprehensive rehabilitation program. I'm a physical therapist, and also I'm a congenital heart patient myself. So from my patient perspective, I can say that rehabilitation, it's really important for kids. And as you were discussing the questionnaires, you know, as a patient, you are born with the disease, so you don't know any other reality. So sometimes the improvement is seen only after, and it doesn't mean that the patient is entering the program and seeing something being wrong or something needing improvement. But at the end, it's like, I didn't know I can feel like this. And I saw it in many of my patients. And we saw the force qualification, the paper from Naomi Gautier from Houston, and I will put in a chat a website, as they create, from the people from Houston, they created international group of people who are interested in pediatric cardiac rehab, and they have annual really nice symposiums in person and online. And for anyone interested, check the website. The website is quite complicated. Let me just check it. And you can join the initiative, and it's very nice group of people interested in improving fitness and quality of life of children with congenital heart disease. So that's what I would like to wanted to share.
Well, thank you very much, Aneska. Thank you for your participation. And I think we came to an end, and thank you very much to all who have presented the 2 very interesting talks. I think they were superb, and it was an excellent topic. Also, thank you very much to the ERN GUARD-Heart people for allowing us to participate in this webinar. Thank you. It was a fantastic webinar. Thank you very much.
Thank you, Dr. Anjos, for the moderation of this webinar. And for your information, the webinar will be was recorded, and we will add it to the website. So everyone who wasn't able to be with us can go back to it later. And thanks a lot to the speakers, really fantastic that you were able to be here and give these very nice presentations. Our next webinar will be the 30th of October, the last Wednesday of October, and that will be in thematic area 1 with complex cases of CPVT. Of course, there will follow some flyers, etc. But wish you a very nice evening, and hope to see you later.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Bye-bye.